lactation. And as probably you noticed, there is a slight change with syllabus. So the first three lectures will be drugs in pregnancy and lactation, then the drug development, and then the first lecture of chemotherapy, which all will be recorded during this week. I changed the timing a bit حتى إنه I think إنه الchemotherapy would be better given if in person. Okay, so أنا دكتورة علاء عبيني رح أدرسكم الجنرال فارماكولوجي الثمان محاضرات القادمين. So why do we care about the safety of the drug or the drugs in pregnancy and in breastfeeding? Just a quick clinical reality هاي شفتها في paper منشورة. 60% of pregnant women they have يعني a condition يعني they need to take medication for, and 70% of the pregnant women take medication, and the most shocking thing probably إنه 90% من الأدوية الموجودة في السوق they lack clinical evidence of its safety during pregnancy and lactation. So this is huge. And why is that? Why most drugs lack these important safety data? This is because historically, drug development before 1993, women in general, even women, not even pregnant women, were excluded from clinical trials. In 1993, the FDA set a rule or a law that every clinical trial for a new drug should have women included in their protocol. Now, even with that amendment, women were engaged or were included in the clinical trials. However, pregnant women were categorized as, until recently, were categorized as vulnerable. What does that mean? That mean يعني هدول the drug company where it's more work for when you categorize vulnerable patients. It means more work, more time, and not very profitable for drug company. And drug company were discouraged from including pregnant women in their studies. However, recently they changed that. They removed pregnant women from the vulnerable category, and now you see more research on the effect of the drug, whether a new drug or even older drug, on the pregnant woman. So as a consequence, most drugs were not investigated in pregnant women. There is a lack of safety and dosing data. So this is important, and we will talk about it later. The dosing is very important, and what's happening for many situations, they rely on the dosing of the non-pregnant women, and they use the dosing regime of non-pregnant women in a pregnant woman. What happens is that the pharmacokinetic of in pregnant women is different than the non-pregnant women, and so eventually the dosing may not work. Okay, so if you use this dose regime 3 to 4 times or 500 mg one daily in a non-pregnant woman, probably this dosing is not going to work well in a pregnant woman because of these changes in her pharmacokinetic. Now, also because of the lack of and disencouragement of including pregnant women in clinical trials, most toxicity and teratology studies are based on animal models. And you can guess that animal models do not always, and many times it does not really translate well into human biology. And just a small يعني to put this in numbers, medication introduced in 1980 until 2000, the 91% had undetermined fetal effects. So يعني most of them have undetermined fetal effects. So you don't know if it's going to affect the fetus or not. Only 3% had some known fetal risk, and 6% has no known fetal risk. So more sure, only a really small percentage of the drugs has no known fetal risk. So when every time you give, and most of the time when you give a drug, you probably don't really know how it will affect the fetus. So we said the using the dosing regime in non-pregnant women is not going always to work because there are changes in pharmacokinetic in pregnancy. So what are these changes? Remember, pharmacokinetic is in a small and simple description is what the body does to the drug. So we include the absorption, distribution, metabolism, and excretion. And I think you should, or elimination, and you probably أخذتوها هذا بالintroductory lectures. So what happens when we talk about absorption? So many of these patients will have nausea, so they have difficulty to adhere to taking the medication. First of all, so the doses are suboptimal. They suffer from vomiting. So if it's an oral drug, they will lose the drug probably. As well as some of physiological changes, for example, decreased gastric emptying. So the food is not يعني is going to be released slowly into intestine, and you probably remember that most absorption is in through the intestine and not the stomach. So it probably will decrease the maximum drug concentration, and this probably also will reflect on, for example, drugs will have a delayed response. So if you take a paracetamol and you expect to work in like within half an hour, this probably will take more than 1 hour to work. So the onset of the drug probably going to change. As well as the gastric pH become more alkaline, and this affect the ionized and non-ionized form of the basic and weak acid. Remember, the ionized drug can penetrate the cell more easily and it will be more easily absorbed, while non-ionized, it does not penetrate the cell easily and not easily absorbed. For the distribution, the total body water of the pregnant woman increases, okay? And expanded plasma volume, which means there is increase of volume of distribution of hydrophilic drugs, which means the drugs probably will not reach its target organ at an optimal concentration and will probably have a less efficacy. The same as with the fat, increases the body fat, so the volume of distribution of lipophilic drug also increases. There is a decrease in maternal albumin, and you remember albumin is a plasma protein where many drugs, important protein, where drugs bind to it. So it will affect the free drug fraction in the plasma. So here, when we say decreased maternal albumin, that means there is a decrease in the protein binding. For the metabolism, hepatic enzymes are either induced. Some of the hepatic enzyme will be induced, and some of them will be inhibited. And I'm sure you took it in your introductory lectures that affect the metabolism of the drugs. Some of them will have increased metabolism, while other will have decreased metabolism, and therefore the efficacy and toxicity will affect efficacy and toxicity of the drug. Now, in the pregnant woman, there is increase in cardiac output, which means there is increase in the renal blood flow, which means any drug that is eliminated by renal, for example, in the urine, the elimination will increase. And also there is increase in hepatic blood flow, and also any drug that is eliminated through the hepatic extraction also will increase its elimination. So, to put this in some of these clinical example, just to appreciate what we're talking about, for example, phenytoin, which is an anti-epileptic drug, its hepatic metabolism increases, its renal clearance also increases, and its protein binding increases. When its protein binding increases, this means also the hepatic metabolism and clearance will be increased. And so, therefore, potentially will decrease its plasma level and lead to a breakthrough seizures because it's not working um, effectively at this dose. Another example is metformin, which you can know about, probably know glucophage أو هو منظم السكري. It's an anti-diabetic agent. Its renal elimination increase in pregnancy. So sometimes metformin is not enough to control hyperglycemia in pregnant women. For example, patient with gestational pregnancy diabetes اللي هو سكر الحمل, probably metformin is not enough and probably need to switch to insulin. Another example is an anticoagulant called the low molecular weight heparin. Again, its renal elimination increases, its volume of distribution also increases. So there is a decrease in plasma level and put the patient at risk in developing thrombosis. Amoxicillin, which is an antibiotic, also its renal elimination increases and it therefore potentially could have a subtherapeutic concentration, which leads to failure to eradicate the infection. And some mention potentially could increase microbial resistance. Now, there are factors that can influence the placental drug transfer. Now, the drug transfer through the placenta into the fetal blood is primarily by passive diffusion. However, other type of transfer like it's facilitated diffusion or even other type could also present. However, the primary one is the passive diffusion. So these factors, and you can deduce its effect. For example, lipid solubility. Remember, a lipophilic drug can penetrate the cell membrane, and so they have a higher chance to get into the fetal blood, and the unionized drug as well. So the uncharged drugs are more, they are transferred more easily to through the placenta. However, this impermeability is relative, and so sometimes you can see a drug that is highly ionized in the blood, but there's a small fraction of the unionized uh, drug can penetrate and go through the placenta and make a negative effect. Okay, so an ionized drug, it's not absolutely 100% ionized. There will be a fraction of it's unionized, and probably, and some of these fraction could go into the placenta. And this is what it means, it's relative that rather than absolute. The molecular weight, the smaller the drug, the easier it is to penetrate the placenta. For example, you have the heparin. Heparin is a very large drug, and it is also charged. It's very difficult for heparin to cross the placenta into the fetal blood. This is why heparin is the preferred anticoagulant in pregnancy. The plasma protein binding, the higher the plasma protein binding, so the less free fraction of the drug, the less placental transfer. However, if the drug is high lipophilic, the higher plasma protein binding will not really affect this because it will reach equilibrium very fast between the plasma, the maternal plasma and the fetal plasma. However, this more affects the ionized and poorly lipid soluble drugs. For these drugs, if they have these ionized drug have also a low plasma protein binding, it increases the chances that they can, or the non-ionized fraction of it will go through the placenta. Okay, and the take-home message here as well is that most drug can cross the placenta, but not all. But not all of these drugs will cause a harmful effect. I didn't talk about the placenta itself, but however, the placenta also have enzymes, just like the liver, that can metabolize the drug and can neutralize the drug. So, and probably in the fetal blood as well, there is some sort of elimination of these drugs. So even though most drugs can cross the placenta, not all of them will cause a harmful effect. So to communicate the dangers of giving a drug for a pregnant or lactating woman, the FDA mandates in the drug sheet there is a drug risk category. Okay, so the patient, the doctor can refer to this category and decide whether or not to give the patient this drug. Historically, since 1979 until 2015, the official category was the ABCDX drug category, which, as it implies, it gives a drug a category. It's either A, B, C, D, X. Now, what does it mean? What does it mean to be a drug in a category A? It means this drug has a well-controlled human studies that studied its safety in human and failed to demonstrate any risk to the fetus. This includes folic acid, levothyroxine. Levothyroxine is the thyroid hormone given in hypothyroidism. The B category now, there is no risk in animal studies. However, there is no adequate studies in humans. So you're not quite sure if it's 100% safe. Drugs like acetaminophen and augmentin have this historical B category. The C category means there is a risk that cannot be ruled out. So there is no satisfactory studies in human. Animal study demonstrated a risk to the fetus. So at this point, you are thinking, okay, does the potential benefits outweigh the risk? And the example of that is atropine and ibuprofen during the first and second trimester of pregnancy. Now, D, it's evidence there is a study, there is a clear evidence, there is a risk, whether it's a human or so these studies in humans showed there is a demonstrated risk to the fetus. Again, here, does the potential benefits may outweigh the risk. Example is ibuprofen third trimester and phenytoin. The X category is the contraindication. So these drugs are contraindicated in pregnancy. These are studies in animals or humans, which with well-studied fetal abnormalities, and there is no positive evidence of human fetal, um, or I mean, there is no يعني benefit from taking the drug. So the risk here outweighs the benefits, including isotretinoin, which is used in the treatment of some kind of acne. Okay, so the previous category has some. There are some problems associated with it, so it's very simplistic. The communication of the drug risk is not very obvious, and in moving from one category to another does not really يعني, give you a clear evidence of its the drug safety. Starting from 2015, the FDA issued the pregnancy lactation labeling rule, PLLR drug labeling, to replace the older labeling system, the ABCX system. So it's more a narrative model. We will see an example, and we will see its narrative. They're describing the data present that is present about the drug use in pregnancy and lactation. Provide pregnancy-related information in 3 sections, including pregnancy, lactation, female, and a new section included, which is the female and males reproductive potential. There is no ABCD, no category like this, so it's replaced risk categories. So the idea is to have a better evidence-based, a better communication and better information to make an evidence-based decision. So the patient as well as the doctor can read and decide whether to take or to stop a certain medication. All of these, if you يعني إذا أنت رحت على الدراج شيت اللي بيجي مع الدراج، مو كل دراج فيه دراج شيت الانفورميشن إله. You go to subsection 8 and you can see from 8.1 to 8.3 all of these pillar here: pregnancy, lactation, female and males of reproductive potential. So what's information is in the PLRR for the pregnancy subsection. There is a narrative summary about human and animal studies, benefit risk counseling, dose adjustment, and description of these studies. Okay, in the lactation, the same, similar to the pregnancy, as well as how much of the drug is present in the breast milk and the potential side effects. Now, the newer section, the female and male of reproductive, contain pregnancy counseling about pregnancy testing, contraception, and fertility. So, for example, as females of productive potential should have a negative pregnancy test before starting X medication, okay? Or females of reproductive potential to use effective contraception during treatment of this treatment. And for infertility, for example, this drug may reduce fertility in men while on treatment, or women. It depends. Okay, so all of these information replace the older ABCX system. So if you see here, this Jantovin is the commercial of the generic warfarin. If you have this package insert هذا الدرug sheet يعني information, you go to section 8, you have a pregnancy, so they have a risk summary, so it's contraindicated in women who are pregnant except in pregnant women with mechanical heart valve, and they describe the evidence about malformation found in exposed infant. Then you have a clinical consideration for neonatal adverse reaction. So they have found congenital malformation. How many patients? About 5% of exposed offspring. So it's more narrative. There's more information about the drug. Yes. So in the lactation, there is a risk somewhere from here they say warfarin not present. So there is no warfarin found in milk of the mother. You can use warfarin in and the mother and the lactation and lactating women. However, because of potential of adverse reaction, including bleeding in breast infant, consider development and health benefit of breastfeeding with the mother clinical need. Okay, so again, so all of these advices is more clear to communicate between the يعني, to inform the doctor as well as the doctor easier to communicate with his patient and advise them. For example, here female and male for protective potential, you can see for pregnancy testing, you need to verify pregnancy status for any females that before initiating Jantoven. Also, you need to advise females to use effective contraception during treatment. Okay. So one of the things that keeps one of the terms that keeps appearing here is teratogens. Or the now, what is teratogen? Okay, teratogen from the Greek word terato, which means monsters. Now, teratogens are substances that causes a malformation or it put the fetus in risk. Now, for a teratogen substance to be defined as teratogen, it has to result in a characteristic cell set of malformation, whether gross malformation, or we will see what types of effect teratogen can have. It exerts its effect at a particular stage of fetal development. Now, the fetus goes into three major fetal development, and at each stage, exposure to a certain medication will cause different teratogenic effect. It shows a dose-dependent incidence, so the more exposed the fetus to this teratogen, the more severe and more likely to have a teratogenic effect. Now, teratogenic effect can be manifested as malformation, for example, clit-clip, or it can manifest as intrauterine growth restriction. So the baby is not growing, the fetus is not growing, for example, in cigarette smoking. It can manifest as a miscarriage, especially in the first 2 weeks. For example, when woman drinks alcohol, or as a stillbirth. A stillbirth is when the patient gives birth to her baby and the baby is already dead. The miscarriage is losing the fetus while she didn't give a birth. She lost the baby while inside the womb. Or it can have even neurocognitive delay, for example, learning, sometimes the ADHD, the attention deficiency, could be linked to some of these drugs. So all of these are manifestation of teratogenic effect. Now, the harmful effect of teratogens depends on many factors. First is the nature of the drug. The mechanism of the drug is very important. The dose, route, and duration of exposure. The higher the dose, the longer the duration, is put the fetus into more risk of teratogenic effect. And for teratogen to have an effect, it needs to exceed a threshold dose. So every teratogen, every drug has a threshold dose different from the different drugs. And if it's exceeded, it will have a teratogenic effect. For example, if a patient drink one glass of alcohol, probably will not have fetal alcohol. The baby will not have fetal alcohol syndrome. Okay, from just one drink. Here you need to frequent and big amount of drinks to have this effect. Genetic constitution of both the mother and the fetus is important as well. You know, the pharmacokinetic with the reabsorption, elimination, all is different from one person to another. This also applies to the mother and the fetus. So the maternal and fetal genotypes can affect the drug pharmacokinetic, as well as some of the variant found in women can affect, for example, the a drug. For example of this is the anti-epileptic drugs. Uh, they found that a gene variant called C677T, if it's found in women, in pregnant women, the fetus is more likely to be exposed to the teratogenicity of the anti-epileptic drugs. Okay. And one very important point here is the stage of pregnancy when exposed to drug. So there are a critical period of human development. As we said, we can roughly just put them in three categories: the pre-implantation period, which is the first 2 weeks, the embryonic period from third to the 8th week, and the fetal period from the 9th week onward. And each of these is unique in its sensitivity to teratogenic effect. For example, the pre-implantation period, here they say it's happens all or none. It's either miscarriage or intact survival. Okay, so remember in the first 2 weeks the cells number is still very small, so any major defects will cause either miscarriage, so the patient will die, the fetus will die, or it will be recompensated, and these dividing cell will compensate for these defects, and the fetus will be intact with probably minor defect. Okay, so this is what means by all or none. However, in some studies they are arguing against this all or none, but this is a general rule. Now, example of that is isotretinoin, but however, this drug is very highly teratogenic, and then it is contraindicated in all stages, on all trimesters. However, if it's taken in this first 2 weeks, it will cause a miscarriage. Okay, in the fetus. Now, the second period is the embryonic period from the 3rd till 8th week. Okay, this is where most organs start to form, and we call it organogenesis. This is why it has the maximum sensitivity to teratogenicity. So if you disrupt the early organ formation, you will probably have a defect. Okay. So it has the greatest likelihood of causing structural anomaly. Okay, example include thalidomide and valproic acid. Valproic acid can cause spina bifida and facial clefts, like for example facial cleft, like for example cleft lip اللي هو الشفة الأرنبية أو البالت نفسها تكون there is a cleft in it. Now, the third fetal is the fetal phase. Here, the most of the growth and function matures. So exposure to a teratogen here can cause abnormal growth and function. For example, if to affect the neurological development, may cause cognitive impairment, hearing loss, fetal growth restriction. All of these result in exposure in this fetal phase. Example include tetracycline. Now, tetracycline, as you know, is a drug that is contraindicated in pregnancy because it causes tooth discoloration and bone deformity. The ACE inhibitors, which are a hypertension drug, can cause fetal renal dysplasia if given in the second and third trimester. Okay, just this is one of the probably you took it. I'm not sure when you took the adverse effect of the drugs, but thalidomide, as we said, it causes it's a teratogen and it causes a defective abnormalities or abnormalities in the fetus. And what happens is in 1954, a German company called Grunenthal developed this thalidomide. And first, and then they marketed this drug to treat insomnia and morning sickness in pregnant women. Now, what happens? There are a lot of there are a lot of documentaries about the thalidomide tragedy. I think it's worthwhile to go and have some look at this. But there are a lot of things that went wrong that led to this tragedy. Million of, thousands of women, thousands of babies were affected by this tragedy. Okay, so they what happens is that they did not test this drug in, for example, in pregnant mice. They tested it only in non-pregnant mice. They only used the mice. They did not use any other species to confirm safety profiles and efficacy profiles. So this led to epidemic of miscarriage and severe birth defects. Okay, especially in Europe. In America, I forgot her name. There was a woman scientist that was responsible of the FDA right back then, and this company tried to advertise this drug in America. However, because there were some reports about from doctors about what these doctors started to notice these defects and there's characteristic defect. So there were early reports, and even those early reports and doctors were warning about these drugs, still the company advertised this and marketed and continued to have it in the market. But in America, this doctor prevented the prevented, and they did not agree. They delayed the thalidomide to get into the American market. Okay, so she kind of saved a lot of pregnant and infant back there. So what happens is these what's kind of anomaly, they were very distinctive, and they have this phocomelia, which is abnormal extremities like the hands and foot. You can see here a patient will have ear defect, heart defect, kidney defect. So all of these were because of the use of thalidomide. Now, thalidomide is still be used, but under very strict regulation and under a very specific condition. For example, for a very specific condition of leprosy and multiple myeloma. Okay. After the thalidomide tragedy, a lot of lessons were learned. For example, the FDA asked for the drug to be tested in different species, not only one species, so mice and, for example, rabbits or monkeys or pigs, whatever. And also the thalidomide itself, the drug, it has enantiomer, so it's a mixture of two structurally similar compound, but they have different orientation. I'm not sure if you know the stereochemistry. So one of them were caused this severe anomaly, and then And from then moving forward from this point, the FDA also required the safety of these. If there, if the drug has enantiomers or diastomers, you need to uh, predict the safety of the company need to give data about the safety of each diastomer. Now, another drug with another tragedy is the diethylstilbestrol, or DES, is a synthetic form of hormone estrogen. It was marketed from 1940 to 1970, so almost 30 years. It was prescribed for pregnant women to prevent miscarriage and premature labor, but later found to have no effect. It is found to be a teratogenic, and then it was found to be an endocrine disrupting chemical. So it disrupts a lot of the hormones and the um, glands in the body, the teratogenic effects included the people noticed that the vaginal clear cell adenocarcinoma in the female offspring increased. These female offspring also had congenital anomalies in female um, reproductive tract. Um, and these are the major teratogenic effects. However, there are still a lot of, if you read a lot of, for example, pancreatic cancer or breast cancer, and also in the male themselves. But these are the most two well documented and proved the teratogenic effect of this. So here the key principle, how to prescribe drug during pregnancy. While it's not always easy, we will see, we'll have clinical scenario and see it's not always that easy. So when you prescribe a drug during pregnancy, describe it only when beneficial. So يعني أهم شيء هو الوقاية، والوقاية إنه the pregnant woman does not take any medication. Only use a medicine when expected benefit outweighs the risk. Okay, use the lowest effective dose for the shortest possible time. Avoid non-teratogen. It all makes sense. Okay, avoid newly licensed medication whenever possible, because the older medication probably الناس عندهم خبرة أكثر. They have more data about its safety in pregnancy. Avoid using medicine in the first trimester where possible. First trimester, يعني first 12 years, as we said, it's where the organogenesis happens, more sensitive to teratogens. Okay, so you have this. Please feel free to pause the video or the recording if you want to try and think by yourself and answer the question by yourself. So a 20-year-old newlywed female present to her primary care physician for severe cystic acne. So she has حب شباب, okay, severe form of acne. She has heard about a miracle drug called isotretinoin from a friend and is desperately want to try it. So the question here is, what is the single most important thing you must do before even considering prescribing isotretinoin? Let's say the patient, she has a severe cystic acne and she is good candidate for the drug. But however, remember, she's a female in her 20 years old, so possibly can get pregnant. Okay, so um, this drug is extremely teratogenic, and it's well known documented teratogenic, and it's contraindicated in pregnancy. So what you need to do here is, first you need to confirm that the patient is not pregnant. You need to ask the patient to do a pregnancy test. If the test is negative, then you need to advise the patient and inform her that she needs to use effective contraceptive عشان ما يصير عندها حمل أثناء التريتمنت. Okay. If she's pregnant, you need to advise her not to take the drug. It is contraindicated, and not prescribe her the drug. because acne is not a life-threatening, well, it's annoying. It's not a life-threatening disease. After pregnancy, she can probably resume and try to take isotretinoin. Now, the second scenario is in the chronic diseases. Now, here are three women on the same drug. However, the conditions are different. Patient A, now valproic acid, the drug is valproic acid, and all these patients, let's say they are pregnant. Okay, so patient A is bipolar patient, had history of manic episode, stabilized by valproic acid and symptom-free for 3 years. So bipolar patient, it's a يعني هو مرض psychological، يعني مرض نفسي. There is chemical disturbance بالbrain تبعهم. They will have a episode of mania, which mean they either يعني they're إنه يعني manic episode will be, for example, very they have a very strong euphoria, or they will not think rationally, okay, or they will be in a very depressed mood, and maybe they will be suicidal. So this patient probably tried different drugs, and valproic acid stabilized her, and she was symptom free for 3 years. The second patient she has epilepsy. And again, she had frequent seizures and been in seizure free for also almost 3 years using the valproic acid. So in these two patients, the bipolar and the epilepsy patient, both of these drugs, both of these diseases are considered as serious diseases, and they need to be stabilized. Whether it's the depression, the manic episodes, you need to prevent these manic episode in patient A, or to prevent the seizures in patient B. All of these can, if the pregnant woman had a manic episode or a frequent seizure during her pregnancy, this will affect both the woman and the um, and the infant. So it is important to control the symptoms. However, let's see patient C. For patient C, she's using valproic acid for severe migraine, so headache. يعني عندها severe headache. And valproic acid seemed to work fine with her. It reduced her episode to only 1 mild every other month. However, what do you think? In which case the benefit do not outweigh the risk? Which one is easier to decide whether to stop or to continue valproic acid? You probably answered right. You probably answered patient C. Yes, patient C here, valproic acid in this condition is contraindicated. The risk outweigh the benefit here. The risk of having teratogenic effect outweigh the benefit of having less severe headaches that could be controlled by probably less effective drug but more safer drug. However, in patient A and patient B, well, you can advise the patient that she can change her drug to a safer drug, but again, probably those she tried those drugs before, they didn't work for her, and there is a risk for the both patient and fetus in this case. So it's not always clear in patient A and B whether they need to stop valproic acid or not. And if they decided to continue on valproic acid, probably you need to supplement them with a high dose of folic acid to reduce neural tube defect risk. Okay, the last section is the drugs in lactation and breastfeeding. So the drug transfer into breast milk, again, depends. There are key factors that influence drug passage, include lipophilicity. So you guessed it right, the more lipophilic, the more transfer. For example, diazepam is highly lipophilic, so caution advised when taking diazepam. The smaller the drug, the less molecular weight, the more transfer into breast milk. For example, in lithium, there is a warning. It should be used only in full term, not in مثلا الخدج. يعني full term يعني جايب بشهره كما تام إنه وزنه صح، يعني هذا full term infant. And there should be a close monitoring of the fetus when if the lactating if the mother's is using lithium. The higher the protein binding, the less drug transfer. For example, warfarin is highly protein bound with minimal milk transfer, and this is why warfarin is indicated and in while breastfeeding. The drug half-life, the longer the half-life, the more risk of exposure. For example, diazepam and nordiazepam, nordiazepam is the active metabolite of diazepam. They have a very long half-life, extending to even 100 hours. So there is a risk of accumulation in the fetal blood. Okay, so how to reduce infant exposure? First of all, timing of breastfeeding. So if let's say this patient takes her medication once daily, so you can advise her to take the drug just before the longest sleep of infants, and then and this is because if she takes the drug, okay, let's say in the morning her baby يعني صحي من النوم, so this is the longest sleep, and she takes the drug and then immediately start breastfeeding. لأنه أغلب الظن إنه لما تاخذ الدرج يحتاج وقت حتى يصل its peak plasma concentration. أغلب الظن إنه ما راح يصل it's the least amount of يعني الدم الدرug, it needs time to get into the blood of the mother and reach its peak plasma. So this timing is perfect for this. However, if it's taking a drug that requires multiple dosing, she can give تاخذ الدرug just after breastfeeding. So she just finished the first breastfeeding, take the drug, and then we'll give time for the another dose حتى يعني another إنه next breastfeeding there is time حتى البلد يعني الدرج الجسم يتخلص من الدرج and the concentration يكون أقل. Okay. Use short-acting drugs to limit exposure. Monitor the infant for adverse effects like sedation, irritability, or feeding issues. Of course, you choose safer drug alternative with a drug with proven safety profiles should be chosen. Now, the pump and dump this is sometimes the lactating woman أو يعني the woman who's breastfeeding she needs a short course of treatment, but this medication is contraindicated in when she is breastfeeding. So what does she need to do is stop breastfeeding for during this treatment period, maybe give the patient her baby a frozen pumped milk or a formula, and she keeps pumping her milk and then dump it. Why is that? Why doesn't she needs to pump and dump during this period حتى يستمر عندها الفسيولوجيكال production of milk, because if she stop pumping الجسم بيتوقف عن إنتاج المilk. فafter this short treatment she can resume to breastfeeding. Okay. Okay, therapeutics of selected situation. The first one is the analgesic and antipyretic, so for the pain and fever. The safer options is drug of choice, acetaminophen, whether in pregnancy or in in lactation. Now, ibuprofen, it's a non-steroidal anti-inflammatory. It's safe in lactation. However, you need to avoid it in late pregnancy, okay? Because there is a risk of premature ductus arteriosus closure. هذا يعني it can cause a deep increase البريشر على البلمونري pulmonary blood vessels, so it's a dangerous malformation. The cautious now be caution be when you prescribe aspirin. However, sometimes aspirin is needed to prevent diseases like thromboembolic diseases and some high-risk pregnancy, to prevent preeclampsia. So here, doctors prescribe low-dose aspirin, not a high-dose aspirin. And low-dose aspirin is kind of safe to give in these high-risk pregnancies. Now, the risk of giving aspirin للpregnancy and lactating women is because there is a risk of Ray's syndrome. So Ray's syndrome يصير عند الطفل بعد viral infection، خصوصا بعد viral infection يصير عندهم fatty liver. يعني اصلا انت الاسبرين ممنوع تعطيه للطفل اذا كان عنده حراره، يعني اذا كان اذا الطفل عنده حراره viral infection لا تعطيه اسبرين، لانه there is a risk of this race symptom. يصير عندهم يعني ياثر على الكبد، يصير عندهم dangerous fatty liver. Now, antibiotics, the safer options are penicillin, like amoxicillin, cephalosporins as well. The drug to avoid, we mentioned tetracycline, because there is a tooth discoloration and bone growth. So tetracycline is contraindicated in pregnancy. In lactating women, it could be used in short courses for less than 3 weeks. The reason for that, when they measured the tetracycline in the breast milk, they found it has a small amount of tetracycline, so low excretion into breast milk. And another factor is, I don't know if you took this, tetracycline. When you give a patient tetracycline, you advise them not to take them with milk or any calcium supplement, right? Because there is a chelation reaction when tetracycline is given with calcium. The chelation reaction will prevent tetracycline from being absorbed. So here the same. If this small amount, let's say the infant drink this, this tetracycline, the milk itself, the calcium, will prevent the absorption in infant. So the exposure of the infant to tetracycline is really small. So this is why can be used in short courses in lactating women. However, in pregnancy, it's not. It should be avoided. Aminoglycoside like gentamicin can cause ototoxicity and nephrotoxicity, and they should be avoided. Okay, that's us. If you have any question, please don't hesitate and write me in Teams or when I see you next week. And yeah, good luck.